Now into lecture 3 for cardiovascular disease this week. So now we'll finish off the other remaining contents for this lecture. And we'll firstly have a look at the pathophysiology behind congestive or chronic heart failure. But before we begin, let's have a look at some statistics. For heart failure, it is actually quite common to see in survivors of those who have had an acute myocardial dysfunction, but particularly in those who have systolic dysfunction. And when we have a look at the pathophysiology behind heart failure, hopefully systolic dysfunction makes a lot more sense to you. So it's estimated that 300,000 Australians are affected by heart failure, which equates to roughly 4% of the population above the age 45 years old. 30,000 cases are diagnosed, or new cases are diagnosed each year. And unfortunately, once it's diagnosed, it has a very poor outcome. So as we can see here with the statistics, 20 to 30% have a 1-year mortality rate, and this is seen in mild to moderate chronic heart failure patients. However, with increasing severity, so in severe chronic heart failure, there are 50% of these individuals who die within 1 year. Now to distinguish between sort of the stages and what congestive heart failure versus chronic heart failure is. So congestive heart failure, or the initial stages of heart failure, is seeing that there is inadequate systemic perfusion by the heart to meet the required cardiac output for the rest of the body. And this happens due to a defect in the heart's pumping action. Now, when we have a look at the different types of heart failure, this will again make a lot more sense. And with heart failure or congestive heart failure, we can start to begin to see the buildup of fluid in particular organs, so the lungs, liver, kidneys, or the legs. Now, this is quite important in terms of understanding heart failure because it's something you need to monitor closely with patients, particularly weight. These individuals actually do need to weigh themselves on a regular basis to monitor any form of fluid retention, just because of this buildup of fluid that is now happening in their body. Now, chronic heart failure, which should come as no surprise, is long-standing heart failure. So once it is diagnosed at this point, or it reaches this point, the heart muscle itself has now had irreversible damage that has been done to it. And the main outcome treatment for these individuals is that we try to make having a look at different types of heart failure. So between systolic and diastolic heart failure, systolic is the most prevalent between the two, occurring in about 60% of patients. Now, having a think back to what the cardiac cycles are between systolic and diastolic, remembering that systolic during the cardiac phases, systolic is the phase where we have the contraction of the myocardium to push blood to the rest of the body. So it makes sense that if we're talking about a systolic dysfunction of the heart in heart failure, it is the inability to contract forcefully. On the flip side, diastolic heart failure, so we know that the diastole phase of the cardiac cycle is involved with cardiac refilling. Therefore, it is associated with an impaired ability to refill into the ventricle, or depending on what part of the heart is affected. So this can then result in either left or right-sided heart failure. And there are a few causes that result in heart failure. So we can have our CAD, which leads to an acute myocardial infarction and then results in myocardial weakness, which makes a lot of sense, particularly when we're looking towards systolic heart failure. Viral infections and alcoholism, which again can lead to a weakening of the myocardial muscle itself. Any types of valvular diseases, so we have stenosis as well as calcified valves within the heart. And unfortunately, what then happens is that we have this increased rate of filling, or it causes some form of backflow since the actual valves themselves do not do their job correctly. And hypertension. So how hypertension works, and it is very common to see individuals who have had chronic hypertension eventually develop chronic heart failure, is because of this heart that is continuously working, so particularly looking at the left ventricle, to push blood out at high pressures in order to meet the cardiac output demands. This picture provides a good summary of right versus left-sided heart failure. So we'll start off with the left side. So number one is saying poor left ventricular contraction results in poor heart emptying and increasing pressure back up to the lungs. Remembering back to basic cardiac physiology, that the left side of the heart is receiving oxygenated blood from the lungs to then pass into the left side of the heart to then have the left ventricle push this blood to the rest of the body where it is needed. Now, with this reduced ability to contract, the blood that is still remaining within the left ventricle has nowhere else to go except back from where it came from. And this is why we can see this increasing pressure or build-up or fluid backup in the lungs for number two. Unfortunately, in left-sided heart failure, this creates more problems because pulmonary edema, which is fluid build-up in the lungs, can be a life-threatening situation. This needs to be monitored carefully, and it needs to receive medical attention straight away. But there are things like shortness of breath that results in your pulmonary edema, and it should make a lot of sense that you should see that. And it will result in other problems for these individuals. So we have one area where we're having this fluid backup, and then unfortunately in another area where we're not getting enough of that outflow of the blood. So we're talking about for number three, we're not getting enough blood to go to the rest of the body. So as a result of that, these individuals in particular will feel fatigued all the time because they're not getting the right amount of oxygen to provide what they need for their metabolic needs in everyday activities. Now, if we look at the right side of the heart, so if we have poor right ventricular contractions, there's going to be a pressure backup and fluid backup within the venous system itself. And unfortunately then, as a result, because remember, the right side of the heart is going to eventually push blood, the deoxygenated blood, to the lungs to get reoxygenated, we now don't have this good outflow or good cardiac output to the lungs to get this done for us for gas exchange. So this is where, so for number four, you're going to start seeing the fluid in the extremities in particular and the kidneys. Now for number five, it says poor outflow to the lungs and pressure backup to the right ventricle. So because now that we're not getting this blood to go to the lungs because of that poor contractility, remember, like I said with the left ventricle, that blood, because it's not getting pushed out, it will go back to where it initially came from. So if there isn't enough pressure to push it to the lungs, it's going to come back to the right ventricle. As you can see from these complications, it puts a lot of stress on the heart, and some abnormalities or different structural changes will arise as a result of this. So looking at left-sided heart failure. So the most common cause for left-sided heart failure is hypertension, and that will be as a result of that continuously working left ventricle or the myocardium to push the blood at a high pressure around to the rest of the body. And what you will commonly see in left-sided heart failure is left ventricular hypertrophy, particularly if it is a systolic dysfunction. It can be as a result of ischemic heart disease, mitral valve or aortic valve disease. So for example, at the aortic valve, so remember that is the valve that the blood must pass through to go through to the rest of the body. If there is a dysfunction at that valve, so if it's got stenosis or it's calcified, this is where we can have something called valvular regurgitation. So essentially just that, so backflow back to where it came from. And this again can create problems for the heart. Circulatory failure, so a hemorrhage and then impaired atrial filling. Now, having a look at common causes for right-sided heart failure. So left ventricular failure is the most common cause for right-sided heart failure. And hopefully now this makes a little bit of sense. So we can imagine that there is now this backup and fluid buildup that is now occurring just because we have this insufficient left ventricle, which is now pushing blood back through to where the right side was. So it'll go back through the lungs and affect the right side of the heart. So then naturally, any form of lung and pulmonary vascular diseases would cause right-sided heart failure. And again, it's just so because the right side of the heart is now overcompensating for what's happening at these sites. Any sort of pulmonary valve disease, circulatory failure, so a hemorrhage, and congenital heart diseases. So what we've got there is shunt lesions. So shunt lesions refer to an abnormal connection that allows blood to flow directly from one side of the cardiac circulation to the other. So in a left to right shunt, it actually allows the oxygenated pulmonary venous blood to return directly to the lungs rather than being pumped to the body. And then in a right to left shunt, it allows the deoxygenated systemic venous return to bypass the lungs and return to the body without becoming oxygenated. So in each of these cases, both left to right and right to left shunts result in the circulation being less efficient, and it creates an increased demand on the ventricles. So this is where we can see most definitely how chronic heart failure can result as one of these types of lesions. So the common signs and symptoms of chronic heart failure, so the fatigue due to that inability to get that cardiac output to where it needs to go, a reduced capacity as a result of that reduced cardiac output, swelling from the fluid, all right, so which is why weight is very important to monitor for these individuals, and shortness of breath. So we can use an ECG to have a look at an underlying pathology involved with chronic heart failure or congestive heart failure. And we can use it to identify left ventricular hypertrophy. So this is when we usually see failure of the left ventricle or dysfunction of the left ventricle. So when you do your ECG lecture next week, try and go back to this ECG strip and see if you can identify the particular waves that we're talking about. So in this instance, the only thing that you're worried about is the QRS complex involved with an ECG. And what you'll need to do is add the larger S wave of leads V1 or V2 in millimeters, and then add it to the larger R wave of V5 to or V6. And if the sum is greater than 35 millimeters, then it's classified as left ventricular hypertrophy. So when there is this increased mass, there obviously is quite a bit of conductance trying to get through this through this muscle mass, and which is why we see these heightened waves at each one of these sites. Finally, we've reached the exercise component of cardiovascular disease, so we'll now have a look into cardiac rehabilitation and what that entails. So it involves a multidisciplinary approach to treatment, and this is extremely important for these individuals because there is a whole bunch of different things we need to try and manage and ensure that the patient gets the best out of the cardiac rehabilitation experience. So besides exercise, the other components that cardiac rehabilitation really touches on are psychosocial and vocational counselling, medical surveillance and emergency support, and risk factor modification. So the goals of cardiac rehabilitation are to improve functional capacity, to alleviate or lessen any activity-related symptoms, reduce disability and maintain quality of life and independence, and identify or modify any coronary artery disease risk factors. The unfortunate reality is that only up to 38% of eligible patients participate in cardiac rehabilitation, which leaves more than half the patients who should be receiving cardiac rehabilitation not even going into these programs. There are different phases that cardiac patients, particularly those who have had some form of cardiac event, acute cardiac event, that they go through. And initially, so in phase 1, we call this inpatient rehabilitation. And this can be up to 7 days depending on the procedure and the cardiac event. So for example, if somebody did have to have a CABG and quite an extensive CABG surgical intervention, this will then usually require up to the whole 7 days or even a few more days on top for inpatient rehabilitation. However, in a process like an angiogram, it usually, if even, requires 1 day of inpatient rehabilitation just to ensure that the site itself has been properly sewn up or taken care of to ensure that it will heal properly. So in phase 2, we have outpatient rehabilitation. And in programs in Australia, this usually lasts 6 to 8 weeks in hospitals. And this usually consists of exercise components, usually 2 to 3 days a week, where it is supervised by exercise physiologists. Some do see physiotherapists for certain other treatments. And then after the 6 to 8 weeks, this then goes into maintenance, so phase 3. And any sort of other programs that these individuals would like to go into, if they do like the community-based feel or they like that someone's supervising them, then there are programs that most of these hospitals, when they do offer outpatient rehabilitation, have a whole bunch of community-based programs that they can offer patients. However, it's from this phase 1 to 2 and this process and education about how to help them continue with a good sort of lifestyle and how to change their risk factors. Phase 3 really, it is their responsibility to try and maintain this healthier lifestyle. So is cardiac rehabilitation actually effective for those patients who come in and have it? So there was a meta-analysis done a few years ago, and it looked at different types of patients who had different types of cardiac events or surgical procedures. So we can see down at the bottom there were CABG patients. PTCA is percutaneous coronary angiogram, and MI, so myocardial infarction, angina, and all of these individuals were middle-aged men. So what they were looking at were different supervised exercise programs for 6 months, as well as those who just completed the comprehensive rehabilitation. So if the individuals only performed exercise, there was still a significant mean difference that was obtained for total mortality as well as cardiac mortality. While the mean difference for non-fatal MI wasn't statistically significant, having a 4% reduction in non-fatal MIs is a very huge clinical significance for the individual. Compared to comprehensive rehabilitation, so we can see that total mortality and cardiac mortality did not achieve as great of a decrease in the mean difference. However, the non-fatal MIs did receive a higher mean difference compared to the exercise-only intervention. And as you can see in the comprehensive rehabilitation, it was only the cardiac mortality score that was deemed statistically significant when they ran the analysis. So it is really important to see how good exercise is for these individuals, because a lot of the goals behind cardiac rehabilitation we really can target. Let's have a look at the exercise prescription guidelines according to ACSM for outpatient programs. So exercise physiologists are predominantly involved in outpatient programs. Sometimes they might be involved in inpatient programs the early mobilization stages for that. But generally, physiotherapists and exercise physiologists have a bit of a crossover between inpatient and outpatient programs. So for the aerobic exercise prescription, there are a whole bunch of modalities that you can do for exercise prescription. However, it is extremely important that you take into consideration what type of cardiac event they had and the surgical procedure that may or may not have been involved for that individual. So for example, we'll use the sternotomy example again. There are certain guidelines that you must adhere to before you can even do certain exercises. So if I knew that I had a cabbage patient who would come in and see me at 4 weeks, I know I can't give them an arm crank exercise because they cannot, or they're not allowed to perform upper body exercises until a certain week post intervention. So you can see that a lot of the exercise modalities are large muscle groups. We want to get them exercising as frequently as possible, so from 4 to 7 days per week. Again, remember these guidelines are exactly that. They're a guideline. If you are initially exercising someone, you should not, for someone who is completely sedentary, 4 days a week is quite a lot. Just consider how you will progress that person. So get them to eventually meet the guidelines, but you don't need to straight off the bat get them to 4 days a week. So the intensity, so for the warm up and cool down, you're looking at less than 40% of their heart rate reserve, or lower RPE. So for the actual work component of the aerobic exercise prescription, you're looking at an RPE between 11 to 16 on the 20 scale, or between 40 and 80% of heart rate reserve. So if the person does have angina, so this is what we're talking about with the ischemic threshold, you need to prescribe the RPE or heart rate reserve just below that ischemic threshold. And how you measure for that is when the individual does go through their stress test, and it is a requirement for these patients to go through a stress test. And those results will show, hopefully, the point at which in the test they had angina and when it first came on, and the severity of that particular pain score. So when it comes to that, make sure that you prescribe the intensity below that. When it comes to heart rate reserve, it's usually 10% underneath that. If the patient is on beta blockers, prescribe using RPE. So as I mentioned previously, beta blockers blunt the heart rate response. Therefore, when we're looking at intensity and the effort that the person is producing, it is a better measure to actually collect RPE as opposed to the heart rate, because the heart rate response isn't necessarily completely reflecting what the person is doing. So then for duration, so we have warm up and cool down, 5 to 10 minutes, and the session itself should take 20 to 60 minutes. Again, start gradually and make sure that when you take these guidelines, you take in the considerations of where the person is at initially. So as it says there, even ACSM is telling you they can even start between 5 to 10 minute sessions, and you can build this gradually even from 1 to 5 minutes in duration. For the exercise prescription guidelines for resistance training in an outpatient program, it is important that we do target the major muscle groups for the individuals. So we have 8 to 10 different exercises that either incorporate a chest, back, legs, shoulders, arm, abdomen, and hips muscle groups. And these can be targeted by using therabands, light free weights, wall pulley systems, as well as pin-loaded machines. The initial frequency should start off at 2 to 3 days per week, with at least 48 hours between sessions. And initially it's 1 to 2 sets per exercise with 12 to 15 repetitions at 30 to 40% 1RM, so quite a light load. If the individual is at a low risk, you can increase the intensity by prescribing 8 to 12 repetitions at 60 to 80% 1RM. But the RPE prescription for intensity is 11 to 13 on a 20 scale. Remember, it is extremely important that you have the all clear from their specialist to make sure that the surgical incisions have healed before they commence any form of resistance training, particularly upper body resistance training. And don't forget to neglect flexibility. So it is important to target the major muscle groups, again, with static stretches or mobility range of motion exercises. Please try to avoid dynamic stretching with these individuals, particularly with the healing process of their incisions, and not to mention the individuals you'll generally be dealing with when it comes to cardiac rehabilitation are elderly individuals, and dynamic stretching really isn't an appropriate type of stretching for these individuals. So it can be incorporated with the aerobic warm-up or cool down for their session, which it is in the ACSM guidelines. Perform 1 to 2 sets of the stretch and hold them for 10 to 30 seconds and to the point of discomfort. So there is a lot of evidence to suggest that when a person gives a subjective recount of how they felt during that stretch and it was at the point of discomfort, this actually got the greatest results in flexibility. Special considerations for surgical procedures as well as implantable devices, starting off with coronary artery bypass grafts, so a CABG. It is important to note how many bypasses grafts have been put in place, because it does give you an idea of the extent of the damage to the myocardium for this individual. So multiple grafts indicates that it was a more severe event. In order for surgeons to do this, generally a sternotomy is done or performed, and this is when they open up through the sternum to access the heart to perform this surgical intervention. The exercise guidelines for these individuals for the first 5 to 8 weeks post-surgery is that for any lifting activities with the upper extremities, it is limited to quite light weights. So we can see that it's 2.27 to 3.63 kilograms. And the reason for this is if we have a lot of movement through the upper body, something called sternal deviation can occur. And unfortunately, if the individual hasn't given the sternum enough time to heal and they've had a bit too excessive movement with a lot of stress through the upper extremity, the sternum itself will then deviate away from its correct position, which will then require the person to have another surgical intervention to put that back into place. So avoid this by following the correct guidelines. For an angioplasty, the incision is looking for the femoral artery, which is generally done in the groin. And for these individuals, exercise shouldn't start any sooner than 5 to 7 days. And you must get the all clear from the specialist to say that the catheterization access site has been healed. For individuals who have pacemakers, it is important that you ask and also record what the type and settings of the pacemaker are. And for those individuals who do have a fixed rate pacemaker, make sure that you use RPE as the guide to figure out what the intensity levels they are exercising at. For anyone who comes in with an implantable cardioverter defibrillator, and these individuals usually have a history of an abnormal cardiac rhythm, you need to limit their target heart rate to be at least 10 to 15 beats lower than the threshold discharge rate. Because if you were to prescribe an exercise that does reach the intensity that will get to their discharge rate, it will set off the defibrillator for no apparent reason and then shock their heart to thinking that it needs to go back into normal rhythm when it's already operating fine. General special considerations for cardiac rehabilitation patients should be that you are constantly monitoring for any abnormal signs or symptoms that an individual might have. So these can include angina, shortness of breath, or any unusual fatigue. Supervision is always recommended for moderate to high risk patients. For a low risk individual, if they seem quite competent at the exercise they are performing, then you may give them minimal supervision. However, always double check and monitor what their signs and symptoms are, how they're feeling, and get them to report back to you. Always use small increments for progression in their exercise prescription, and the minimal frequency of exercise for these individuals to start off with should be 3 days of the week. And also make sure that initially that these are non-consecutive days. For the exercise prescription and special considerations for chronic heart failure and congestive heart failure, you need to read the ESSA position statement that is up on Leo, the SLIG paper, 2010. And yes, it is accessible in the weekly quiz. So please make sure that you do take notes on the exercise prescription and the special considerations, because these are important for you to understand for those cardiac rehabilitation patients. If you have any questions on this lecture, could you please send me an email? Other than that, that's it for the cardiovascular lecture.